Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dolph Simons Family Studio. We are delighted to be back with you on this chilly and cold but crisp and clear Monday morning. 20 degrees outside. That was a little cold. But the numbers, Hawk, how are the numbers today?
Numbers are good. Numbers are a lot better than we hoped for.
Yeah, they were up to 102, I think, on Friday, as I recall.
Yeah,
that was a big number. And then today?
So today we have 82 active infections.
That's
new
really
infections,
good.
Which is really good. 37 of those in the ICU, so even our ICU number has come down, and then 24 on the ventilator as well. So those critically ill seem to be a little bit improved as far as total numbers from last week. We still have 76, though, total for that recovering. So 158 or so active and recovering infections. And then Hayes has improved as well. They have 26 total patients with 21 of those active and 5 in the recovery. So luckily, it looks like the hospitalizations right now are down.
Yeah, I like those numbers. I like the trend. And I was looking at the Kansas City numbers. You know, we hit a peak of like 1,300 last week, one day. I don't remember, it was Thursday or something. And then over the weekend, usually a little lower testing on the weekends, but 800. I think it was lower on Friday. So maybe that's a start of a good thing. We'll see. You know, it's funny when you and I are calling 82 a good number.
I know.
I mean, I remember when we were like 33. Well, oh, that's bad. And now it's 82. Oh, that's good. So nothing like a little bit of framing to help you understand what's going on. Hey, we are really excited about today's guest. We all probably know people who are passionately for or against vaccines. I was out this weekend down in the Ozarks and stayed at a place that I go to a lot, and it's out in the woods, and you can get a cabin, and it's a gorgeous spot, River Life Farm. But the gentleman down there who is a purveyor there, you know, I just know there are a lot of folks that some people want to wear masks and some people don't, and you know, you just have to be thoughtful and try and do your best because and they have some concerns about vaccines too, and I saw that in the stations we stopped at to get gas coming back. You hear people talking about, you're gonna get that vaccine. I'm not gonna get that vaccine. You're like, no, go get the vaccine. So, you know, they might be family or friends, coworkers, people you know really well. Our guests today, though, are going to help us have a better understanding of what drives the passions and inspires us to successfully take on crucial conversations, especially when you're trying to talk with people who you care about and you love about whether or not the vaccine is right or not right for them. Dr. KU, Professor Donna Ginther is back with us, and so is KU Professor Dr. Brett Bricker. We'll talk with them directly. But first, let's see if there are any reporter questions out there.
Hi, good morning. Cody Holyoke with Channel 9. Curious about, now that, you know, we've all seen this video, people were lined up in Michigan watching the Pfizer vaccines go into trucks and go onto planes. Have you received any shipments yet? What is the plan moving forward for this week, and what's your timeline updated now because of the approval over the weekend?
Yeah, well, first of all, we're delighted to say we are going to be getting vaccines this week, and it's coming up soon, Hawk.
Yeah, absolutely. You know, the CDC and all of those organizations, Operation Warp Speed, have really kept delivery secret. We know that Kansas will start receiving the first doses or the shipments Monday or Tuesday, and it just depends really what site you're at if you're going to get it Monday or Tuesday. We have been in contact with KDHE because, again, all the vaccines right now are distributed through the government and then down to the state level government. So we are working with them. Again, not sure if it will be Monday or Tuesday, but really by Monday or Tuesday, all the sites in Kansas should have their shipments. So,
you know, it was a fascinating story to read about how that's being delivered, and then to look at the partnership between Walgreens and CVS and how they're taking care of nursing homes, because individual pharmacists from Walgreens and CVS are going to different nursing homes to deliver the medications. I mean, getting in their car and driving the medication. I mean, it's a pretty impressive way that that's been designed, and man, so much work has gone into the planning of that. So, Cody, we hope to be able to talk about giving vaccine here either Tuesday afternoon or Wednesday morning, but it's going to come really soon. And I tell you what, I can't wait. I'm not going to be getting it because I'm not first in line, but I can't wait for the moment we start giving vaccine here at KU, because that is the beginning of the end of COVID, and I'm really looking forward to that.
I was going to ask what your spirits are, what your mindset is with all these frontline workers who have just been nonstop dealing with this for months and months and months and months. What's the sense on the floor right now as this starts to become available?
You know, here's what I think. I think it's hope. You know, the deal is that until the patients and everybody in the community gets vaccinated and keeps wearing masks, remember, you got to keep wearing a mask, until we really get COVID under great control and eradicate, not fully eradicated, but get it at a much lower volume than it is today. But I think when the numbers start going down and our hospital staff can feel life returning to normal, that's when the real celebration starts. The vaccine is a symbol of hope that will protect our staff and ultimately our community from getting COVID-19. So vaccination is about both science and it's about hope. And I think both are really important. I used to, I still practice CF. In fact, I'm rounding on the inpatient cystic fibrosis ward this week. And you know, we used to go to the CF meetings, and you would go to the meeting, and at that time, there wasn't a lot of therapy for CF. And I mean, we had extended the life of up. When I first started in CF, it was 17 or 18 years, and today it's in the mid-40s and going up. And I remember when I would go to the meeting, one of the guys I was with, he turned to me and he said, you know, this meeting is 50% science and 50% pep rally. And the pep rally is more important because you can get so down dealing with the disease that takes the lives of young people. I think in the battle against COVID, vaccination is 50% science and 50% pep rally or hope. And both are important. The science is what's going to help us conquer this, and the hope is what's going to help us get through it. Vaccination is about hope, and it's about science. And I'll tell you what, those are great Christmas gifts that we all need right now. Other questions from reporters?
Good morning. This is Dan Cohen at 41 Action News. I wanted to ask about the timeline for other members in your hospital. What are those conversations like? Because obviously the frontline workers are first in line, but you know, other hospital staff who are at possible risk of exposure. Any conversations there?
Oh, there's a lot of conversations for sure. The first thing is that it depends on how many vaccine doses we get.
Yeah.
We're going to go, and the way we're doing it is duration and intensity of exposure to COVID-19 defines where you are in the order of getting the vaccine. So it's really the frontline workers, ED, respiratory therapy, environmental services, physicians, nurses, everyone who's in the front line, ICU, floor teams, pharmacists. But then it begins to work its way through depending upon the intensity and duration of the exposure. How long that will take us will be entirely dependent upon how many shipments of vaccine we get. And we really won't know that for a couple of reasons. First of all, we have to find out how much the Moderna vaccine, if it's going to be approved. Now, I think it will be, but we don't know that yet. We don't know how much ultimately we'll be getting a week of the Pfizer vaccine. And then we don't know the status of the AstraZeneca and the J&J vaccine. So not trying to be evasive at all, just trying to be honest about it. Because until we know those numbers, Hawk, it's difficult to predict exactly when somebody's going to get a vaccine.
Yeah, absolutely. You know, we know in general around the nation and in our region, whether you're talking about the Missouri side or the Kansas side, the allocations have just been small. I mean, there's just small amounts of vaccine that are available right now. We know that those companies are ramping up their production. So initially on that, even in those first line, those first tiers that Dr. Stites had mentioned, we may have to stratify there as well. But certainly getting for the highest risk people first.
Yeah, I think one of the important features is just like the flu shot, remember that getting a vaccine or getting a flu shot, sometimes you get a little bit of a fever, you get a little bit of a headache, you may not feel as good. Well, you know, in the age of COVID, that means you can't go to work. So what we have been saying to our staff is, and to our teams is, look, let's say it's an ICU unit, we can't vaccinate everybody at once, because if everybody has the symptoms, or even half the people have the symptoms, which is what it is with the flu shot. I mean, this is no different than that. If somebody has a headache or a low-grade fever, they can't go in and work in the ICU shift. So we can only do a portion of those folks every day, and that's fine because, you know, frankly, we're not going to have 10,000 doses on day one to give to everybody. You know, we'll be in the low hundreds or mid hundreds or whatever the number is, and as those numbers escalate, then we can give it to more folks. Other questions? All right. Professor Ginther, you recently did some research around mask wearing among Kansans. Together with your expertise as director of KU's Institute for Policy and Social Research, do you have any insights into why some people are rejecting what could be called simple science when it comes to wearing a mask?
I think that people are a little reluctant to admit that there's a problem. You know, we'd like this to go away, and wearing a mask kind of reminds us that there's a problem here. I think that may be one reason that people don't wear a mask. I think there's, been a lack of leadership about wearing masks. If we have it modeled as good behavior, I think then more people would be more likely to wear it. So I'm hoping that, people realize that the vaccine is not going to be here immediately, and we need to continue to take precautions to prevent the spread of COVID, and mask wearing is an important step in that direction.
Yeah, that really does make sense. The research around vaccines is much more complicated to understand than masks. In your opinion, would you expect to find the same people who reject masks to reject the notion of getting a vaccine?
Unfortunately, I think those two are correlated. I think that people who are reluctant to admit that COVID's a problem, or saying that it's happening to somebody else but not to them, are going to be reluctant to take a vaccine. And all of the noise around how vaccines is really problematic. Our vaccine is wearing a mask now and getting a vaccine when it's available is going to be our only path out of this crisis. So we need to really emphasize the importance of taking both using a mask and taking a vaccine. And we need our leaders to publicly get the vaccine. I remember when we had H1N1 and President Obama got the vaccine in public. I think having our leaders take the vaccine will assure the public that this is an important step in preventing the spread of COVID going forward.
Yeah, it's interesting. When we were traveling this weekend, I was down in the Ozarks again and came back, and I'm fascinated that in the rural parts of Missouri, and again, I'm a lifelong Missourian, in the rural parts of Missouri, not a lot of mask wearing. Now, we get into Springfield, a lot more mask wearing, and a lot of mask wearing in Kansas City. Now, I know that there's got to be rules around that, and that's part of the deal, that the metropolitan areas have said there's a mask mandate. But even that notwithstanding, it feels like there's this big schism between rural and urban areas around just simple facts. Help me understand that better.
Well, I think that the COVID-19 unfolded in the cities and it unfolded on the coasts, right? And so it happened to other people and not to us. And unfortunately, because of all of the, propaganda or, noise about how, this isn't a problem, we're in a situation where people are not going to take this seriously until it affects them personally, until somebody they know gets sick or somebody they know, heaven forbid, dies. And so, we really need to kind of reverse that and tell the story of how important it is to prevent the spread of this disease.
Yeah, I think that's really true. Hey, now, does the economic fallout around this pandemic play any part, do you think, in mask wearing? Do you think that's going to influence it one way or the other?
I think people have, during the election, people were, it's COVID or the economy. And, my point of view is that the economy, you need to solve COVID before you fix the economy. So they go hand in hand. And you're not going to see a return to a full, robust economy until we get COVID under control.
And Professor, you've also done some research around the racial breakdown in NIH research funding. Does the disparity you found there relate, do you think, at all to the disparity with this virus and perhaps trust in healthcare in general?
Well, I think that there is a big mistrust of medicine in communities of color, and that we need to do a lot of work to ensure trust. I don't think that the funding gap was so much related to this level of trust that we need to really strengthen and reestablish. And the way to do that is to engage with the communities and engage with the thought leaders. And this is true of rural Missouri and rural Kansas. We need those leaders to understand in those communities and to convey the message that COVID is real and that we need to do the right thing in terms of wearing a mask and getting a vaccination to prevent this from dragging on through 2021 and into 2022.
Well, Dr. Brett Bricker is a nationally ranked debater and the assistant director of debate at KU. By the way, I was a debater a long, long time ago. We won't talk about how long ago that was, but that was, and we were nationally ranked back then, but it was a very long time ago. I'm not sure anybody would even remember those rankings. Would the mask research, so debate forever, would the mask research above be a good starting point for a conversation with someone who might not buy in to mask wearing? Why or why not?
So I certainly think it is. I think it's very helpful to be right or correct in these conversations about mask wearing. And I think Dr. Ginther's research and some of the examples that you all have provided on this show about the effectiveness of masks in COVID units definitely speaks to that. But I think something that you've alluded to, Dr. Stites, is that convincing someone to wear a mask is much more than just about convincing them that the science is accurate. Someone might believe the science, or it's not really just a problem of ignorance. We're dealing partially with a problem of values, and the choice not to wear a mask is sometimes related to an expression of individual freedom. So they care about their own freedom to make their own choices more than they care about the health of themselves or their surrounding community. And sometimes it's a problem of values of selfishness. They care more about themselves than they care about their community. And if they are a young person or a healthy person, maybe they perceive themselves not at risk, and they just don't really care about the spread within the community. So communication about masks needs to be focused on the science, like Dr. Ginther's, but also on reinstilling values of community and breaking some of the more selfish trends that we might see, for example, in your conversations on your trips.
Yeah, I think that's right. And so help me a little bit, especially around the research with anti-vaxxers, which I know you've done that research before. Do you think there's a correlation between the fears related to other vaccines and fears around the COVID vaccine? How do we convince people to take this?
When you said that we're dealing with a problem of 50% science and 50% hope, that's a really interesting way to phrase it, because I've been thinking about this as a problem of 50% science and 50% persuasion. And I think answering your question is difficult, but I want to let me explain for a second. So when we talk about anti-vaxxers, most of the time we're thinking about those people who are really beholden to conspiracy theories. They might believe, for example, that the MMR vaccine causes autism, which has been widely disproven by large-scale CDC studies. When we're talking about the COVID-19 vaccine, I think it's important to distinguish audiences a little bit differently from those traditional anti-vaxxers. So when I think about this audience, or the group of people that are going to be asked to take the COVID-19 vaccine, I think it's useful to think of them as three different audiences. Audience one is the audience that is ready to roll. They're the front of the line. When their name is called, they'll be there. They might have fears, but those fears are dramatically outweighed by their support for their community or their health, or just the positive benefits of the vaccine. The second audience is what I call vaccine hesitant people. And these are not really traditional anti-vaxxers. These are people that they have questions. They want to know about the emergency authorization. They want to know about how the vaccine corresponds to autoimmunity or immunity disorders. And these people are rational, persuadable. They're open to having a conversation on the subject. They're looking for the right evidence. And these people are not like traditional anti-vaxxers. And I really think that when we talk about this issue, we should mostly be talking about vaccine hesitant people, because these people are, early research has shown this is about half of the U.S. population. It's the largest group of these three audiences I'm going to talk about. So this is kind of the most important group. And then the third group is more the traditional anti-vaxxers, the ones that are very beholden to conspiracy theory. They don't trust science or evidence. They're going to get most of their information on the subject from fringe websites or blogs. and this group matters, but these are not as large of a population as we should make them out to be. So when we talk about the COVID-19 vaccine and we think about learning from previous campaigns, we need to think about hesitant people, people that want their questions answered, people that want to find the right information. And I think that's how we should be designing our conversations and our campaigns.
Yeah, that makes total sense, because I think that you're right, that I don't think there's any problem with being vaccine hesitant. You just want some proof, you want some more knowledge, you want to understand what it means for you, you want your primary care physician to recommend that and things like that. So I think those are all good sense. So have past campaigns around these kind of medical messages taught us how to be more persuasive?
I think they have. And I think that there's some information that we can glean from historical examples. And I kind of organized this by just thinking through some tips for how institutions should design their campaigns based on some previous campaigns and previous evidence. So I have 4 of them. I'll be kind of quick. The first is that I think what we've learned from previous campaigns is that pro-vaccine messaging needs to both provide the evidence and a defense of medicine, science, and those studies that were done to produce that evidence. Because if someone doesn't trust the scientific enterprise, just merely restating findings from the scientific enterprise will be insufficient. This is kind of a long-term project. You know, I think as a nation, we're losing trust in governance and institutions, and Dr. Ginther mentioned, for some people, medicine. So I'm not sure that we can fix all of that in this campaign. So 2, in the interim, it's important to find people that are trusted to represent this campaign. And the vaccine rationing is going to complicate this a bit. So I like that we have 3 former presidents that have stepped up and said that they're willing to get the vaccine. I don't think that they will, or don't think that they should be allowed to jump the line and get the vaccine in front of other more needy people. So we need public faces of the campaign, but we need public faces that fall within the rationing order. So, for example, if step 1 is finding cancer patients, finding a publicly visible cancer patient might be that gets the vaccine, publicly speaks about its effects, and is willing to kind of publicize that. That might be something that would be really helpful for building trust amongst people. And I think that this should be targeted. So when I'm thinking about this in terms of like Kansas City, for example, you know, finding recognizable faces, George Brett, Andy Reid, Sly James, those are some faces that might matter. Third, I think we should use narrative and some visual evidence. So something that I've followed your program pretty closely, and something I think you all do very well, is to demonstrate individual stories. And you've talked to a long hauler, you provide some strong visual evidence at the end of a lot of your daily briefings. I think those are really great areas of focus. And then finally, I think one thing that we can learn from previous campaigns is that campaigns need to prepare for the worst, or prepare for the unknown, and recognize the power of a negative anecdote. So we should expect that some people will report negative health effects. We should expect that some of those won't have anything to do with the vaccine itself, but people will assume and maybe publicize that those have to do with the vaccine. And even if these are extreme outlier cases, those anecdotes can be very, very persuasive. And I think campaigns need to account for that.
Yeah, I think that's well said. Hawk, I mean, you've got to hear that from your patients some about vaccination. What do you think?
Yeah. You know, even we do vaccinations all the time for our HIV population, for our populations that we examine for getting liver transplants, because they have to be vaccinated prior to transplant. And there's always questions. We certainly try to answer them as best we can. And most of the time it works. But just as we heard, you know, sometimes it doesn't. But we have a good track record and good proof for these established vaccines. For this new one, it is much more difficult, and I think that hesitancy there is okay. But if you are hesitant, again, do your due diligence to do your research to look at that. Don't just say you're hesitant and not examine it further. There are now good public data about that, good public resources for looking at the data and getting all that science information from the vaccine for safety and efficacy.
Jill, let's see what questions we have out there.
Great. All right. People have got a lot of recapping of some questions before. One of them is there any evidence that people with cancer the vaccine will only have 50% effectiveness?
No, there is no evidence. That the vaccine hasn't been studied in a lot of these special populations, so there's no evidence that it's only 50% evidence. Now, what we can say, again, for patients that are on chemotherapy who may not have that B cell and T cell immunity or function, for patients with HIV/AIDS or other medications that allow their immune system to not function as normal, we don't know if the vaccine will take, if you will. That means we don't know if it will cause an immune reaction to give you immunity. But that is not isolated to this vaccine. That is in vaccines in general.
Isaac wants to hear from the panel. What's a good response to people who say they're hesitant because they think the vaccine was rushed?
All right. Dr. Ginther, what do you think? What can we say about that?
Well, I've worked with people at the NIH in the past. These are the best scientists in the world. One of the reasons why this came about so quickly is that the mRNA approach to creating a vaccine is very precise. And so they actually got the sequence for the vaccine within a couple of days because of using this new technique. The fact that they went through all stage 3 clinical trials, had tested the vaccine on 30,000 people, gives me confidence that what we have is very effective. So yes, it was fast because our technology is better. And this mRNA approach has been proven both in the Moderna vaccine and the Pfizer vaccine. So it was fast, but it's because our science is good.
Dr. Bricker.
I think Dr. Ginther summarized it perfectly. I really don't have anything to add.
Hawk?
Yeah, I think it was expedited, but there are very good reasons for that. And we have to remember part of that expedited process is all those volunteers in the United States and other countries that were stepping up and wanting to do that as well to show that it was safe so we could get this information out, get it analyzed, and get it to the public. So I think that's why it was expedited and because of the great need for it as well.
In times of great crisis, you have to try and do things that perhaps are a little out of our standard fare. Remembering that China and Russia pushed a vaccine out before there had been trials, it was more theoretical, and they started using it. By comparison, both Moderna, Pfizer, J&J, Johnson & Johnson, and the AstraZeneca vaccines, as well as many others, have been studied extensively, not just in the United States, but throughout Europe, in South Africa, in the Middle East, in South America, Brazil especially, Argentina. I mean, these are places that have all had the same experience that the U.S. has had. There have been very few problems with the vaccine, and that really shouldn't surprise us. Because even though the technique is new, the concept and the methodology is old. And vaccines have been around for many years now. Remember, they've helped us eradicate smallpox. Vaccines have helped nearly eradicate polio. We get them every year for influenza. MMR protects us. Your diphtheria vaccine protects you. You don't step on a rusty nail and die anymore because you've been vaccinated. Vaccines are safe, and they have been used time and time again. So what I would say to you is that, does it feel rushed? Well, it's faster than you've experienced before. Not as fast as some parts of the country where they really did do phase 2 and phase 3 trials. But the reality is that in the midst of a public health emergency with over 300,000 people having died, you can feel, as long as the science is strong and the research is safe, that the vaccine is safe. Remember that between Moderna and Pfizer, these vaccines, the mRNA ones, have been given in over 60,000 people. Now, by comparison, when we do new drug research in CF, we release those drugs after 200 or 300 people have been tested because we don't have a lot of patients to test. 60,000 people is a massively large number to do a health research on. And also remember that the results, the complications of vaccines show up. Remember we said within 4 to 6 weeks, and we've waited 8 weeks. You say, well, that's not long enough. Well, yeah, actually it is. And messenger RNA vaccines have been used before. This is not the first messenger RNA vaccine, as we learned from our colleague from Mayo Clinic last week. So I would urge you to remember that while it may feel fast, medicine has moved so much better than it used to. Science is so much stronger in this area than it once was. And our ability to synthesize and make these vaccines has come far along. So I think the vaccines are safe. And when it's my turn, I'm ready to go, Hawk. How about you?
Yeah, absolutely. You know, we want to make sure we get it out to the right people, but it is safe. I was just, again, reviewing the side effect profile from the Pfizer, from the FDA briefing again. Again, still very safe. We have to understand that this mRNA technology, just as you said, is not new. It's an older technology. I mean, it's newer compared to some of the other vaccine technologies that we've used, but it didn't just pop up in 2020. It's been used and looked at and studied in other types of diseases as well.
A lot of people are asking about side effects. Can you, did you have an opportunity to look and maybe study or?
Yeah.
We
Yeah,
did.
I was actually
Unfortunately,
looking right
those-
before this.
And anybody can see it because you can go look at the FDA document online. It's very long. You can read the Pfizer document. It's even longer. Or you can look at the New England Journal of Medicine article in which it's a peer-reviewed publication now, which for us, that's a really big deal. So it's peer-reviewed, meaning others have put their eyes on it, critiqued it, sent it back, and they've had to answer those questions and change the art, et cetera. So that article is published. That was published last week, and it's available online to everyone without a subscription. So if you want to see that data, it's right there for you to look at.
Yep, and it looks like, you know, a lot of people, so 85% may get some site injection site reaction, which is just going to cause pain, and they mild to moderate pain, really mild pain, meaning it just aches a little bit. You don't need any Tylenol or anything. It doesn't affect your
Which is true about
daily
influenza
living. Right.
and worse with some others. I mean, right, the
Tdap
shingles
is-
vaccine, Tdap,
tetanus has
MMR,
traditionally
oh
been
my
a bad
gosh.
one.
Right.
So
this is not a surprise.
Right. Smaller percentages, 15% of people may get fatigue, a little bit smaller percent may get headache, and I think it was around 5% will get the fever. So very small percentages on those other ones. Certainly we know that where the vaccine is injected, you're probably going to have some mild amount of pain that's just going to ache throughout the day.
And just to say, the second injection is, because it's the second one, your body's going to react a little bit more strongly to a second one. We'll have a few more symptoms with it. But all of these symptoms do go away in 24 to 48 hours. And again, folks, it's the same thing you get with influenza in terms of the side effect profile. So it's really pretty darn mild.
Yep.
Lots of questions. Riva wants to know, what are some other messenger vaccines that we have been using?
You know, they again, a lot of this was started with SARS, the original SARS.
SARS-CoV-1
vaccine. You know, luckily that disease really just died out because they were able to contact, trace, and identify, and it was different infection dynamics at that point. So after that, kind of the funding dried up, so they really kind of stopped looking at that. They've also looked at it for some other viral diseases as well. They were studying it for MERS, which is another type of coronavirus infection. And those cases still do happen, mostly in the Arabian Peninsula, but they do occur every year. They are still working on that as well. So if you go back to SARS, at least, that is more than a decade ago. So this technology has been looked at for over a decade.
I would just like to say, we have a lot of people asking when I can get the vaccine, da-da-da-da-da. And I think that I would like to say to those people that Dr. Norman with the KDHE and Governor Kelly are on tomorrow, which I know you're going to talk more
we're gonna
about in a
talk about
second. But I think some of these questions related around when they can get it, that those would be good people to ask those questions to.
You bet. But what we can tell you is it's a 4 to 6 month timeline for everybody. And what we hear constantly throughout the country is expected by July 1, we should have had enough vaccine for everyone to get it, providing the AstraZeneca and then J&J trials and those vaccines are approved, because there will be a volume number, as well as there's a distribution challenge. But I think we'll figure out the distribution challenge. A lot of work from a lot of folks. But I think that we got to make sure we have enough vaccine in the pipeline between all 4 of the major makers.
There are some people, so it sounds like you may have some insight. There are some people that are like writing and saying, my 90-year-old grandmother not in a nursing home, how does she get it?
Yeah,
Somebody who says,
we'll,
I'm
we'll
working.
answer those questions more tomorrow when Dr.
home
Norman's
health?
on. Yeah, because
Okay.
that is the kind of type of plan. The way it's worked in the U.S. is that the CDC and the HHS have issued guidelines to states of how to do this. in terms of the rank order of patients. And then once it gets to the states, the distribution is done at a state level. And the exact who's going to get it when and where is at a state level for planning. It's not at a national level, with the exception of the Walgreens CVS combination delivering to nursing homes.
And
because that's taken a broad, because you had to work with those two groups.
Yeah, and I'd like to clarify too, we saw articles last week saying, well, maybe Pfizer isn't able to deliver as many vaccines as they initially said. In another article with CNN, the CEO said that in 2021, though, they are going to be making 1 billion doses just themselves. So we hope here in Kansas we'll be getting vaccines today or tomorrow. We just don't know exactly. It's going to be any time between today and Thursday. And that's provided that there aren't delays in shipping, there aren't delays in production as we move into 2021 now, and the other companies are going to be able to keep their production ramped up and have all those vaccines. But hopefully, just as you said, by 4 to 6 months, especially if those other companies are approved for vaccine distribution, we will have doses to get out to the mass populations as well.
Christy wants to know what the panel would advise her. She says, what can I say to a loved one who won't take precautions unless forced to, and says the virus is survived by 99% of everyone?
Dr. Bricker, what do you think? How do we convince people that the virus is real, they should take those precautions, and especially trying to do it for the people you care about?
So when we get to the place of trying to convince people to take the vaccine, an absolute prerequisite is going to be convincing them that COVID-19 is dangerous. Where people get their information sometimes shapes the way that they view this. So, for example, if someone believes that 99% of people survive and therefore they should not really be worried about it, I might point them towards some of the evidence of people facing long-term health complications or the really severe effects of COVID-19 when someone does get it, and the risks of people that, sometimes people assume that it's just people in nursing homes that are dying or just older people. And one thing that you all have done a great job on this show is demonstrating that that's not really the case, and that there are really kind of unexpected people that face complications from it. As we get to the vaccine conversation, beyond just COVID-19 being a problem, I think it's important to have those intimate interpersonal conversations on the subject. And that requires a personal connection. That requires maybe you telling your story about how you came to know that COVID-19 was a problem. Maybe it's someone that you knew or someone close to you that got it and had effects. I remember the first conversation that I had with someone about it who got COVID-19 talked about not being able to smell or taste for a really long period of time, and losing a lot of weight and feeling unhealthy for a long period of time. But so those interpersonal conversations can really help. But I think that the prerequisite is having those facts ready, watching the Medical News Network, keeping up with the WHO and the CDC, KDHE, those places that provide the really useful information for creating those persuasive effects.
Dr. Ginther, thoughts?
We need to tell stories. People are not persuaded by numbers, unfortunately. It's a very few people who look at data and can understand that it affects them. I was emailing with a friend this morning whose older parents both have COVID, and her dad is coming home and going into hospice. These effects are real, and we need to say, how people's lives are affected by this disease. We need to have people share their stories, so that people who are skeptics can recognize themselves or their experiences in other people's stories.
Hawk?
I don't have much to add. I mean, these are experts right here. I totally agree with everything they've said.
I do too. I know in the clinic when I'm trying to talk to a patient about something, And there are new therapies all the time. We act like this vaccination, well, we never encountered this before. New drugs come out all the time. So in the CF world, this new drug came out called Trikafta. And Trikafta is a game-changing drug in CF. It's a miracle
Absolutely.
drug. And some of my patients wouldn't take it. In part, they were worried about how their lives are going to be changed. They were used to life as it is. And you know what I learned and I've known in medicine for a long time is you can't, as you said, Dr. Ginther, you can't just talk about the numbers. You have to personalize it. You have to make it feel personally relevant to everybody you meet and everybody you see. And I think if you can make things personal to them with the illustration of stories, then I think that you can convince folks to do something, but it takes time. If we expect people to take this on its surface and just be okay with it, well, as Dr. Bricker pointed out, there are those who are going to do that. Then there are the vaccine hesitant you're going to have to spend more time with to talk to them. You have to personalize it. And then there are the real vaccine deniers, and I think they're only going to be truly convinced when it hits so close to home and so many others have gotten it and survived that they begin to change their mind. Because when your mind is fixed, change comes harder. So I think we all have to keep an open mind and just try to remember to tell our stories and make it personal every day, every moment. We are all in this together. And instead of being angry, what we have to do is we have to persuade. And anger doesn't persuade. Anger alienates. It's not what we need to do right now. What we need to do is reach out.
I think for our last question, I'm going to combine several people, and can you just recap the vaccine? Like how many shots you have to have, how long before it's effective, who are good candidates for it as far as you know. Those seem to be kind of the, and can I get COVID again once I get the vaccine? How long is this immunity going to last?
Okay, Hawkeye.
Wow,
Let's
that's
go,
an
buddy.
easy one.
Yeah.
Get them all.
Just do the 101.
Okay.
Vaccine
So for the
101.
vaccine, right now, I believe it was really tested in 16 or above or 18 above. So really right now it's only going to be the
16 and
adults
above, I think, yep.
that are going to be able to be vaccinated. Now, as they work through this, hopefully children will be tested, but that's not new. This occurs with really a lot of types of vaccines that first come on the market. So there will be further analysis to look at childhood. Who can get it? Again, most everybody who is going to be 16 or above. What about special populations? So certainly for people like who are immune suppressed, it's most likely going to be safe. Again, this is not a live virus. This is just genomic material to create a part of the virus, and that's the spike protein. So for those, it's most likely going to be very safe. What about pregnant people? Right now, the line of thinking and the direction is if you are in those initial groups that can get the vaccine, meaning those frontline workers, those essential workers, and you are pregnant, it can be offered to you. Also speak with your OB-GYN as well. But right now, again, it hasn't been tested in those groups, but that is going to be, I believe, the wording from the ACIP who makes those recommendations is you can still offer to those pregnant patients. So offer it to them. If they want to get it, they can get it, but talk with your OB-GYN before that. So that is who will get it. What is it? It is a 2-dose regimen. You get 1 dose. If we're talking about Pfizer, it's a second dose 21 days later. If we're talking about Moderna, it'll be 28 days later. When can you get it? So you get the first one, and then at that 21-day mark, you are given a grace period of 4 days between there. So if you miss it on that 21 days, that's okay. You can still get it. You do not restart if you go beyond that date. But in general, 2 shots, 21 or 28 days apart, there is a 4-day grace period in there. You will start to mount an immune response after that first dose. But to get full immunity, you are not really going to be considered to be immune or have that full immunity built up until 2 weeks after that second dose. Which again will be 21 or 28 days. We don't know exactly how long it will be. We suspect that after the second dose, you will have immunity for some time, at least that 6-9 months or a year time period. We don't understand right now if there will be boosters that will be recommended. More than likely, we anticipate there will be. but we don't know that right now. So yes, you need those 2 shots. You will not be fully protected after that first vaccine, so it is important to get that second vaccine. And even if you miss that exact day, remember to try and get it as soon as possible. So that is kind of about the vaccine and the timing. What are the side effects? Again, based on that FDA briefing, many people will get just site reactions, which is really where it's given in the deltoid. You'll get some arm discomfort or pain. Most of those people that got it didn't have to take any pain medication, and it didn't alter their daily life or what they're doing. A less percentage will have fatigue and headache, and even a less percentage of those, probably around 5 to 6%, will have some sort of fever or temperature elevation. Those really should go away within 24 to 48 hours, much like the other vaccines as well. So I don't know, were there
Well
other
done.
questions?
No, I think you did good with that. I think we're going to
Answers?
turn around. Hey, tomorrow, Kansas Governor Laura Kelly and Kansas Department of Health and Human Services Secretary, Health and Environment Secretary, Dr. Lee Norman, join with updates on our vaccination and the virus spread, how it's going to go in Kansas. Don't miss this. I think that's going to be a great program. And we get a lot of questions about these things. And Dr. Norman and Governor Kelly, I'm sure will be able to help us with some of those answers. I want to say a special thank you to Dr. Ginther and Dr. Bricker for being part of our program today. You guys did great. Final thoughts for our audience this morning. Dr. Ginther.
Well, I want to update you on some of our mask research. We started looking at other outcomes, and we found not only do masks prevent cases, they also reduce hospitalizations and reduce deaths by about 50%. So masks are working, and they will help prevent the spread of the disease. So I think, it's going to be a while before we have the vaccine, so please wear your mask.
And it helps keep the economy open when you do those things. If you want to keep everything open, wear the darn mask. Dr. Ginther. I'm sorry, I said Dr. Ginther and I meant Dr. Bricker. I'm sorry. And by the way, I wanted to point out, I loved it when you 4-pointed your first argument. Well done.
Thanks. Always a debater. For my closing thought, I would just like to encourage people to have open and honest conversations with vaccine hesitant people. If you know people in your family or close friends or relatives that you think might be vaccine hesitant, reach out. Figure out why they believe what they believe. Acknowledge their fears and their concerns. Try to develop a rapport with them and provide and kind of end your conversation, even if you don't fully convince them, end that conversation on an area of agreement, either agreeing to take the vaccine or agreeing to find more information about it, or even just agreeing to continue the conversation in the future. Those are ways that you can help build, through interpersonal connections, a less vaccine hesitant population.
Thank you. Thanks to you both, guys. That was great, and welcome back anytime. Hawk, final thought?
Yeah, we're excited. This week should be very exciting for vaccine distribution and supply and the ability to give it. We will give it here at the health system to our Tier 1, our frontline workers, based on our stratifications and the recommendations from the CDC and ACIP. And hopefully after that, we can get more supply and give it out to as many people as we are able to. But I don't think that time is too far away. But right now, we are still waiting for, number one, the second EUA, if there is one for the Moderna vaccine, and then the overall vaccine supplies to be great enough so that we can give it to everybody that needs it. And hopefully, again, make 2021 a lot better than 2020 has been.
Yesterday, I was down in the Ozarks, and a very good friend of mine, and a person I care deeply about, asked me, how many people will die because of the vaccine? I said, what? He said, how many people will die from the vaccine? I thought, I don't even know how to start my answer to that. No, I still don't. Yesterday, Patrick Mahomes threw 3 interceptions. Let me ask you something. Did you really ever lose faith in him? I bet you didn't. You may have gotten a little nervous, but he came right back. The team came right back, and we had faith. We mentioned earlier that the vaccine is about hope and science, but really there's that third thread that we mentioned last week. And that third thread is faith. Now, faith in a spiritual matter may be something that comes with grace and is given to us no matter who we are. But faith in your football team or faith in your science or your physician is something that is earned. It's earned based on a relationship that you have. Someplace along the way, we've started to lose faith in our public institutions. But here's what I know. If you have a heart attack, you don't sit at home and deny that a heart cath and surgery can save your life. If you have cancer, you don't deny that you want to get therapy to try and live longer. At what point do we have to remember that faith applies to the treatment of COVID-19 as well? This can be the beginning this week, in the next day, maybe today for some places. In the United States, this is the beginning of the end of COVID. We've had hope to carry us here. We've had science to get us here. Now we have to have faith to follow those to take us from here. So remember, faith, hope, science. These three things together are the beginning of the end of COVID-19. We'll be back tomorrow with Governor Kelly and Secretary Lee Norman. We hope you're there to join us. Have a great day.